everyone here? So real quick, I just want to take, because this meeting is for you, and this is an information session for you, so I want to make sure that I focus on the right things that are relevant for you. So in this room, who has a loved one who's younger and still walking? Okay, and then those who has loved ones who are or children who are older and are not walking, college. Okay, so what I'm going to do first is just kind of talk about the stages of the disease. Just, some of this may be redundant for some of you, but I want this to be a very practical session. And so I think it's important to talk about the stages because even though there are stages, there's different things that could be done that overlaps some of the stages. And it's important to work as a team to really, in the heart of what Siddhartha was saying, was to live your life to the fullest. Because our job as therapists is to make sure that you have the tools in your tool belt to make sure that you live your life to the fullest, as well as help your child be a child, a young man, or a boy before they are a young man or a boy with Duchenne. And I say that because that's really the heart of when we make a decision, that's what we're thinking about. We're thinking about how can we help your child be as normal and play and learn all the things that any young boy or young man should know or learn. And so just kind of going quickly through some of the stages. So the Bushby paper that was published looked at the different stages of the disease. When you're talking about early ambulatory, middle, late to non-ambulatory. The reason why that even matters is those are the changes. There's different functional changes that happen during that time. And in therapy, when we're talking about these functional changes, that's where we're going to help you the most to change whatever current equipment or assistive devices or therapies to make sure it adjusts and is individualized to your body or your son's body. And so just quickly, in the early ambulatory phase, a lot of times you may see some motor developmental delays, and sometimes you may not. For someone who with an untrained eye, they may not see it. But for those who are used to looking at young boys with Duchenne, they may see it's certain walking patterns and things. And so a lot of times you do hear that kids with Duchenne who are picked up by a therapist or someone who's used to seeing kind of a little difference in the way that the young boy, that your son's walking or running. And so some of the milestones that are difficult for boys with Duchenne would be running, sometimes climbing stairs, and particularly getting up off the floor. So a lot of times, because of the weakness starting proximally, you'll notice that they'll have to use their hands and to help them stand up. And so that's typically called the Gowers maneuver, and that's because of the initial pelvic girdle weakness. Following into the middle and late ambulatory, contractures start to play more of an effect. Usually what I've seen is that in the early stages, even young boys who are just diagnosed, they tend to be already tight at the ankles. And so as they get older, that tightness becomes more of what we consider more of a contracture. So it's no longer mobile, and it's stuck in a certain position. So there's a lot of aggressive management from the physical therapy standpoint to try to manage the stretching. So I'll talk a little bit about that later too. And then as we go into kind of the early non-ambulatory phases, we do use a lot more equipment, assistive technology, and it's always good to know what those are. And it's really hard to sometimes keep track of it because there's a lot that's available. And like I said, you don't have to know all the tools and equipment out there. That's our job to kind of help you. But the only way that we can help you, because there's a zillion things that you could use. Oh, message box. It says it's a temporary problem. Is that we want to make sure that you get the equipment that you need for your home environment. I've seen a lot of equipment being purchased, and it's just used as an expensive clothes hanger. And so unless you communicate with your therapist and your clinical team, it's really hard to you may get equipment that doesn't seem to work for you. There's usually never just one piece of equipment out there. There's multiple different kinds, and just like you wouldn't buy a car without test driving it, you should never get equipment without seeing it and trying it first to see if it actually works. Is it okay? Okay, let's see if it actually is moving. Well, now it's not moving. There we go. Okay, and then in regards to clinical milestones. So what we do know in Duchenne is there's a very predictive loss of function. And so even though there's variability in when it's lost, we know that typically boys with Duchenne lose the ability to stand up from the floor, followed by the ability to climb stairs, and then get up from the chair, and then losing the ability to walk. So that's very typical, and then that's why whenever you go to clinic, what you'll see is a lot of your clinicians will time how long it takes for your son to get off the floor, how long it takes them to run or walk a hallway, because what we learn from the natural history is that timing gives us an idea of maybe when there may be a loss of function. And so knowing that will help us manage and help you order equipment, because as we all know, equipment, you don't go to the store and just buy it off the shelf. There's a lot of work in regards to especially the chairs and things to get in and take 3 to 6 months. And so having the ability to predict when something, a loss may happen, we can better help make sure that you get what you need in a timely manner. And so a lot of times there's, once you get to the non-ambulatory phase, it doesn't stop there. Once a young man gets in a chair, there's other abilities that are lost. And so I was in a group, and this young man with Duchenne said something that was really significant to me. We spend all this time trying to preserve walking ability. And he's like, that's just a means to get from point A to B, right? And so he was like, once I lose my ability to walk, I can get in a chair. But then once I get in a chair, everything that matters to me, that matters to my quality of life, has to do with my arms. But once we get into a chair, or once the young men with Duchenne get into a chair, what do they have? They can drive around, but what happens when they can't use their hands? And so that's something that's been a really big focus in the Duchenne community now, because as studies are moving from ambulatory to non-ambulatory to try to encompass the entire disease, what is it that's an outcome that could be used in trials and such that measures throughout the entire lifespan? And so now, as we go into non-ambulatory, there's also a predictive pattern of loss of function, starting with the inability to reach your head, rolling in bed, the ability to feed yourself and get your hands on the table. That's something that I think we underestimate. If you can't get your hands on the table, there's a lot that you can't do there. And so how can we help make that happen? And then more importantly, the ability to use the phone and computer, because that is now a big social, that's your social community, right, and your outreach. And some of the important things too is that you're always having to prepare for change. And so even though there's different stages, the needs differ between the stages, between school intervention, therapy, personal management, and how often you may see your therapist. That's always a question. Should I see them once a week? How often? And I'm in kind of the mindset of just because you have Duchenne doesn't mean that you are now, you have to have a long-time marriage with your physical therapist, right? It should be where if there is change, that's when you have someone that you can consult to. When it comes to Duchenne, it's a multi-organ disease, and so you need a team that you can trust to come back to if there's a question and when there's change in your life. So really quickly, I'm just going to talk a little bit, since there's some diversity in people's in your people that who have young children as well as older adults with Duchenne. Some of the things that, from a physical therapy standpoint, what we're looking for. So in kind of what they call the presymptomatic stage, some of the small things that you may see are difficulties with language skills, obtaining and understanding language, and some minor tightness in primarily the heel cords, which is at your ankles right here, but the hamstrings may be a bit tight. And then when they're younger, because of the neck flexor weakness, there may be a head lag. So whenever you pull a baby to sitting up, their head lags a bit behind. And then as they get older, they'll have difficulty getting upstairs as well as running, and some of them never even obtain the ability to jump. The Bailey's scale of infant development is a scale that's typically used by therapists to assess like what age group children are functioning at. And so Dr. Connolly at St. Louis did a study using this scale to see if they can see a difference in boys with Duchenne as compared to boys who do not have Duchenne. And they saw significant delays early on, a lot earlier than we expected in the presymptomatic stage. That was picked up by the Baileys. And so now the Baileys is being used in some of the earlier trials as a clinical endpoint because of that. Moving on to early to middle ambulatory. So at this stage, you know, boys with Duchenne are still walking and going to school, but some of the things that you may see more often are increased leg cramping. So they'll go to school, they'll play, and they'll complain about their legs hurting or feeling a little bit more tight. You'll have more tightness, and so then range of motion is going to be more important. So you'll have typical stretching exercises. Who here does daily stretches with your son? So that's going to be really, really important, and it's important to start it young. It's like brushing your teeth. If you start and it becomes a habit, it's something they do every day. Okay. And then when it comes to strength, you'll go into the clinic, and what we see is like the proximal weakness followed by more of the distal weakness. And your therapist may do manual muscle testing as well as maybe using a device that measures the amount of force that they are able to produce with those muscles. And they'll also, you know, you'll see some changes in their walking pattern as their heels get a little bit tighter. Maybe the hip flexors get a little bit tighter. So you see some older boys with Duchenne, their posture changing just a little bit. And what that does is it's compensating for some of the weakness to help them stay upright. And then some of the typical measures that are taken in the clinic, so that your therapists and clinicians can predict what may happen and help you plan your care, are some of the time performance tests, like the getting up off the floor, running the hallway, as well as what they call the North Star ambulatory assessment. Does anybody know what that is? So that scale, what it is a scale that's designed specifically for boys with Duchenne muscular dystrophy in the UK, and it's been very well validated and used for almost all clinical trials for boys who are walking. And it looks at, you know, very functional things like being able to step up a step like you would a curb, jumping, walking, getting up off the floor, all of those kinds of things. And there's a series of 17 questions that the therapist observes and sees how well your son actually performs these things. And there's a score that gives us an idea of where they kind of fall in the spectrum of their abilities. And so we're also looking at the North Star as a predictive value as well, similar to what we're doing on the time test, so that we can help plan care a little bit better. As well as everyone's heard, the 6-minute walk test, and that one's more cardiorespiratory and used in clinical trials. Typically not used in clinic because we never have a hallway long enough, but. Keep in mind, while I'm talking, I don't want to talk to you. If you have questions, just throw it at me. And I tend to talk fast because my life is usually in fast forward. So if I'm talking too fast, just throw something at me and I'll slow down. Some of the changes in the way that boys with Duchenne typically happen. I just kind of want so that you're looking for it, and whenever you see it, then maybe you can contact your therapist to see what you may be able to do. Maybe they've gotten tighter and you need to do more stretching or you know, different kinds of positioning. But what you'll see is an increased lordosis, and what that means is their back is a little bit more arched, and that's because their hip flexors get tight. And so that seems kind of weird to think, okay, if your hip flexors get tight, shouldn't you do this? But the difference is your hip flexors are connected from it's called the iliopsoas. It's from your back, the small of your back right here, to the front of your hip. And as it gets tighter, your back is getting closer together, so you can see this little bit of an arch here, and so they'll have more of a lordosis. They'll also have smaller strides as well as a wider base, and so as the IT bands get tighter, that's something to notice. If their base of support gets wider, you have to do more stretches on the IT band because they're now kind of in this lordotic posture as well as this wide base posture. Okay, and so And then as they get a little bit weaker, they're kind of up on their toes with a wider base. And what that does is they're using their ligaments to hang on to stay upright. That's why, as you see the prediction of when they lose functional ability, walking is the last one that they'll lose, because once they get up there and stable, they just use gravity to be able to and momentum to move forward. And it's less of using muscles, but rather of using balance and momentum. Let's see, going forward. So towards the late ambulatory stage, the most important things to be careful of here is increased back pain because of the lordosis. So making sure that you get appropriate x-rays, just because a lot of, most boys are on steroids, so there's vertebral compressions that can cause back pain. So there's back pain that occurs. That's something that you need to bring it to your clinic team and make sure that that you get x-rays to see if you have any vertebral compression fractures, or if there's other, maybe there needs to be some lumbar support so they'll decrease the amount of pressure that's on their back while they're sitting or when they're sleeping, those kinds of things that kind of help relieve the pain. And the primary thing here is falling. So a lot of boys at this stage may fall and break their break a long bone of some sort because they're on the brink of walking and needing a chair. And so at this time, definitely there should be some conversations about having a chair. And that's a really difficult conversation to have, because it's a big milestone. Because we all think that, whenever you're first diagnosed, that's really tough. And everyone knows the next big milestone in life is losing the ability to walk. And so we are very sensitive to that. And so that's why with these predictive tests, we want to know how, based on how fast your son's walking, we can kind of tell when they may lose their ability to walk. So we give it to you piece by piece. And so it may take 6 months to get a chair, it may take 9 months to get a chair. But as we see that happening, we'll start bringing that up, so that, for one, we want your child to be able to be as independent as possible. And as part of growing up, you have to be able to explore your environment. The minute you can't do that anymore, you can't participate and be part of your network and make friends and be part of the community. And so that's when we start to introduce a lot of the chair things. And then that's where also you're gonna, some of the typical things you're using for stretching may not work anymore. And so there are different things to introduce. And then I think on top of it, all of this, the most important thing is trunk stabilization. As boys, even though trunk stay should be important in everyone's life, but as they start to get into a chair, that's going to be more important, because what's going to hold your spine up are your trunk muscles. And so to make sure that you're used to using your muscles to hold up your spine, there's a lot of activities that could be prevented, and back pain that could be prevented if trunk stave is an essential part of all your activities. So you have a firm foundation to start from. And then making sure that you manage your musculoskeletal health. And so even a lot of people, once they get to the point where they're not walking anymore, we're like, why should I stretch? Why should I use steroids? There's a lot that still happens even after you get into a chair. And so pool therapy is going to be even more important, because in the pool, you take gravity's effect away, and then the stretching is better. You get more movement and support of the water. So even from the standpoint of breathing, it's better. You can open up your ribs more, and then you get the small mobilizations that could happen in the water that may not be done as easily on land. And so you could always consult with a therapist to maybe meet you at the pool for a session and show you a few techniques to help better stretch, help better mobilize the spine. And I mean, breathing is going to be important in the later stages as well. And so breathing is not just the lungs, it's all the muscles that are associated with it. And so if you can imagine, as you get tighter and you look like this, like a lot of us do by the end of a work day, it's really hard to breathe. And so just like they say in yoga, you have to open it up. And so that's part of something that in pool therapy is really helpful. And so advocating for that. And then active assisted exercises. So when you lose the ability to move your arms up all the way by yourself, are there activities that can help, or activities or devices that can help move it for you? Because as the exciting times for Duchenne now is that there are possible therapies that may help decrease the progressive loss of strength or whatnot, and possible drugs available. So what do you need to do? To take preventative action, you need to make sure you manage your musculoskeletal health. And so, because regardless of what drug may come about, nothing can happen if you're so contracted that you can't stand up, you can't move your arms. So any of these awesome robotic devices, minus the actual robot here, if you can't move your arms up, this device that's going to help you move your arm is only going to move it up as far as your muscles allow it. And so musculoskeletal health, as boring as stretching may be, is even more important, just so that you can maintain your skeletal muscle function.
I have a question.
Sure.
My son, he's not in he's ambulatory still, kind of possibly transitioning. He sits to play games. He'll sit forward like this. Sometimes, like, I'll catch him even in like a desk chair. He'll be sitting, he's trying to get closer to the computer, but he's trying to be comfortable. And I watch him in these really bad, weird positions. And I've asked somebody, and they said, no, it doesn't make a difference how he's sitting. But as a mom, and just looking at it and thinking of, keeping everything, it just looks wrong. Does that make a difference how they're choosing to sit versus sitting back and in a better?
So I'll tell you my bias, because I'm a PT, and so position does matter. Question. So I'm going to repeat the question. So the question was, does position matter? This young lady, right? Her son's in kind of middle ambulatory phase, and so playing games and things in odd positions, does that matter? It matters from the standpoint of that, there's this theory, if they can move out of the position, that's fine. But I'm a multitasker. And so when they're playing video games, that's a really good time to do certain stretches as well. To say, for example, you can stretch the hip flexors when they're laying down and playing.
That's the only time he looks like,
right.
I'm like, yay. The rest of the time it looks horrible.
Yeah, and so from that standpoint, you could do some nice stretching. But the other one is, you don't want other injuries associated with bad positioning. So you see ergonomics. So here they have ergonomic analysis to make sure that you don't have repetitive injuries and different things from sitting, because carpal tunnel, all of these musculoskeletal injuries occur because of bad positioning. So if he's playing video games all day long and he's in a bad position, he's kind of going to get stuck in that position, especially when there's muscle weakness and he's not being able to move out of it. So it's really advantageous for you to either consult with a therapist to make sure that you either bring a table that's up closer to him, so he's in a nice position, rather than being in the poor posture. Okay. Anything else? Okay. If not, we're going to kind of go towards the late ambulatory phase. And this stretching is important throughout the entire spectrum of the disease, but night splints and stretching becomes even more important. And then there's also questions that people ask me whether or not a stander should be used, and this is a very individual question, depending on where how much contracture a child may have. If they're too contracted, it's going to be too painful, and it's not worth it. There's a lot of benefits to staying upright, and so a standing device may or may not work, just depending on your child. But stretching is going to be important, but there's some changes in the stretching techniques and whether or not nighttime braces should be used. And this is all going to be based on the biomechanics of your son. So depending on their foot position, their hand position, some things just may not work because the pool is going to be different than it would be if they had intact joints. And the other thing I wanted to talk about are some of the cool things that are used for rehab after a fracture or something. This question comes to me a lot because because there's a lot of pain associated with fractures, and what can you do? And there's a lot of fear that if my child falls, you know, he's in this late ambulatory phase, and he's not walking very well, and he's at risk for falling. If he does fall, will he just entirely lose his ability to walk? And that's an entire spectrum. I've seen patients to be able to get back to walking after a fracture, and those who are not. And it really does have to do with the therapy. There's this really cool Alter G treadmill. Does anybody know what that is? So it's all the what athletes use to rehab after a sports injury. So your body, you're in here, and what that does is it's kind of like water here. They take off the weight, and so you can. So as your child gets stronger, they can add more weight to it. So they can take 50% of the body weight off, 70% of the body weight. So they're still walking and ambulating and moving while their body's healing. And so they don't have the secondary effects of deconditioning and everything else. And so I've seen really great success with this after a fracture. And to tell you the truth, I mean, if people had access to it, it's a great thing for therapy. If you can get use an Alter G, you're getting your cardiovascular workout, just like Dr. Kaufman was saying. This is a really great mode of therapy. It's just a lot of therapy places may not have it. Let's see. Moving on to non-ambulatory, the main thing I want to talk about here are nighttime splints. So that's the question. A lot of times, a lot of young men here I see, they have, you're wearing daytime splints to protect your foot and hold in that position while you're sitting upright. But the nighttime splints become less effective when your foot starts to turn in. So what they call equinovarus. So equinus is whenever you go on your toes. Varus is when it turns in. And so when your toes start to turn in, what happens is that when you pull up, you're no longer really truly stretching the Achilles tendon anymore. In fact, you may even be exacerbating it. And so as your son's foot starts to turn in, that's a time where you should consult with your therapist, because then some of the hand stretching of the Achilles is going to be much better than a nighttime splint possibly. And so that's kind of the problem that we have with nighttime splints. Once a foot starts to turn and you can't get a brace to fit the heel well, it's just not the most advantageous method to stretch the heel at that point. And then so your other questions is, okay, I'm in a wheelchair. Why does it really matter what my foot position looks like? You talk to a young man with Duchenne and they'll say, because it hurts. It really hurts to always be on the side of your foot. And then on top of it, you can't wear cool shoes. And so you have to end up wearing house shoes or something because you can't get your foot into the cool Nikes or whatever it is that's out there. And so so a lot of young men who are in wheelchairs and their foot's turned, sometimes they do get heel cord lengthenings, and that's for positioning and pain. Okay. And transfers, the main thing I want to talk to you about transfers is there's just not one Hoyer lift. Everyone thinks it's just a Hoyer lift, this gigantic thing that doesn't fit into most small houses. There's a lot of different devices like a stand pivot assist, sliding boards that kind of help you make sure that you don't injure yourself when you're transferring your son or your son from surface to surface. And there's there's rolling bath chairs. There's a lot of things to make sure that you protect your body, because if you don't protect your body, you can't help your son, right? And so on top of when you start to have to transfer your son, make sure that you have a session with your therapist and learn what good body mechanics are, so you're protecting your body while you're helping your son too. Okay, and I'm just going to skip through some of this stuff. But in regards to interventions, there's a lot of different ways that your therapist could intervene and help in your daily life, including advising on exercise, so we'll talk about that next, stretching, different types of braces that you may need, environmental modifications. That's going to be huge because, like I said, our only goal is to make sure that your son's able to participate and have the best quality of life that they could have, and remove barriers. And so modifications at school, work, whatever that may be, energy conservation. And so in the middle to late ambulatory phase, how do you conserve energy so that you can actually have the energy to do things you care about? not walking from here to the next place. Okay, equipment and assistive technology. How can we make your life easier? We only can make it easier if you tell us what you have difficulties doing, and there's a lot of things out there. And adapting and modifying chairs, different different things for the house. Okay, so exercise. I'm a little bit more aggressive when it comes to exercise in Duchenne than some people, because I think in general in Duchenne, because initially what you hear is don't exercise, it's going to break down your muscles, and that's it. I think because of that, that's causing some deconditioning and secondary effects that also is as detrimental. So what do we know about exercise in general? If you don't exercise, your muscles get smaller and weaker. Okay, and if you exercise too much, then that's not great for your muscles. Too much as in too much resistance, eccentric exercises. Who here knows what concentric, eccentric, or isometric means? Okay, that's a good one to know. So isometric is when you're holding your muscle in place. So for example, this is an isometric hold of my biceps. I'm not moving anywhere, but my biceps are working, right? And so concentric is me actively pulling my arm up, and so there's a shortening of the muscle fiber. Eccentric is as I am pulling my arm up, there's an elongation of the muscle, so there's resistance against it. And so the last one is the one we want to avoid. So hence you always hear no weightlifting, don't ride your bike uphill, don't ride your bike in the grass, all those kinds of things, because you want to avoid the eccentric, because the eccentric causes the most damage. And so that means when you exercise, what's the best exercise to do? You could do things that are concentric, because that's less detrimental to the muscle fibers. And so there's a lot of activities that combine both. And so I can't address every single one of them, but the important thing is if you can talk to your therapist, they can break down a task and tell you what portion of the activity, for example, horseback riding or gymnastics, that should and shouldn't be done. So that you know, if your son wants to be in gymnastics, it's not a blanket no. There's just certain things that maybe you should modify, and so that's where it's important to develop a relationship with a therapist that can help you individualize your life plans. And then younger boys, in a sense, have more benefit in the sense that you start at a higher threshold, because lots of what we see, what Dr. McDonald's found, that boys with Duchenne are usually 40% less active than other boys. And so as you're growing and developing, you should be gaining strength. They're not gaining that strength because they're more sedentary. Because you're asking a young boy to kind of monitor how much is too much. And so when you think about fatigue, you have to think about multiple aspects of fatigue. There's muscle fatigue when your muscles are actually tired. There's mental emotional fatigue when you're just tired of doing it. And so what is it that they're tired of? And that's really important for them to understand and for you to understand. Some benefits of exercise: maintaining mobility, endurance, decrease atrophy and some of the sedentary, the effects of a sedentary lifestyle. It improves well-being, depression or anxiety. And so this a lot of times whenever someone's in a chair, that's going to be important to talk to a therapist. How can you modify and do activity even if you don't have to, even if you can't walk? And so those are the things, because when naturally we think in the box, when we think of activity, we think of a lot of things: running, walking, jumping, all those kinds of things. But there's exercises out there and studies out there showing that even an arm bike is a good exercise to do. To maintain muscle mass, improve blood